And like Ronsi said earlier, we're down. Let's just get down to business. So I'm here. Thank you very much for this opportunity.
Okay, thank you so much, sir. We can hear you perfectly well. So your voice is really, really, legible. So I'll push it over to champions now. Oya, over to you. If you have any question, Oya, let's go. Let's throw it out.
Hello, Ronsi and Dr. Otene.
Yes, ma.
Good to hear your voice, Dr. Otene, even if I'm not seeing your face.
I wish I could I will turn on my video, but because I am just strolling around, it's a little bit more difficult, and I hope it won't interfere with the network. Let me just do that for a bit. Thank you.
Don't worry, sir. Let's get the talking on. Nice to see your face.
My pleasure, ma'am.
Yes, sir. Nice to see your face. Yes, Champion Khadija Spanwo.
Doc, can you take off the camera? Doc, can you remove the
camera? Because I know that the camera will now reduce the network strength.
Yes.
So yeah.
Yes, please remove it. Perfect. Thank you.
Right, done. It's because Champion Khadija said she wanted to see the face, so I just did that temporarily. Okay, ma'am. Continue.
Okay. Thank you, doctor, for being part of this process, because this is part of the things that we need to encourage some of us that are newly diagnosed and maybe family members, caregivers, to know to be abreast of what is obtainable in the cancer space.
Yeah.
Nobody is happy that we find ourselves in this situation, but when you are in this situation, what we need to probably do is to see how we can make through the system. This is my 13th years anyway. I was diagnosed in 2010. So it's times when some of the newly diagnosed talk to me, I will allow them who have spoken like 2-3 times. I will not tell them that, you know, the person you are talking to is in the same shoe with you. They will start crying and say, no, they can't believe it. And that my voice doesn't sound like one. I say, yes, because you are not seeing me. So I have to try all I could to talk, to advocate with them, to preach, to tell them why it is important to recognize our oncologists, no matter what the situation is. Because once in a while, you have it necessary to get across to the oncologist. Whether you travel abroad, you don't travel abroad, whether you are in Lagos. If you are in Lagos, somebody can talk to Dr. Otene where he is. Because even some of the people that, if to say everybody is here, you see people telling you that they are calling from Gombe, me and in Abuja. But I keep telling them, forget about where you're calling from. The most important thing is ask what you need to ask and know what you need to know and know how you too will get somebody a survivorship under your care too. Under the care means you are giving the person what is expected as probably an advocate, a survivor, a health counselor, to in whichever way you can support whoever that is in the shoe. You give it to them, to the family, to the caregiver. You are not only taking care of the patient, because most of the times I tell people that fine, we ought to get along with the patient, but there are some situations that you need to talk to the family so that they will know the kind of support that is expected of them too, to be given to the patient involved. So that is why most of the time support group meetings, we welcome beyond the patients.
The champions.
Yes, this champion. And at times because we started with breast cancer support group, it doesn't mean that we are not into some others cancer too. So that's why our name changed from breast cancer support group to network of people impacted by cancer in Nigeria, so that we could take care of some other not really gynecological cancer beyond that. We have people that will call, my son is this, my great-grandfather is this, my father is this. So you see, it goes beyond breast cancer. Because that was why when we're rolling out the link, I said, no, we shouldn't just think about breast cancer support. Let's go beyond that. If you're able to get some other things, they will go around this. So honestly, if you ask for me candidly, I would prefer the new ones that have never participated in this monthly meeting to do so and ask whatever question they need to ask, whatever they need to know about it, about the.
Okay, thank
Hello?
you. Thank
I
you
can hear
so
again. Okay.
Thank you so much, Madam Khadijat. I'm not sure if I get her final question, but I think she was trying to motivate champions to ask their question and feel free to contribute.
Exactly.
What they don't want to.
Yeah.
Then
So,
we all work around.
yeah. So champions, if you have questions, please feel free to just turn on your mic and ask your question. And Dr. Otene, if you want to respond to what Madam Khadija has said or any other person.
No. I think what she did was, like an encouragement. Thank you very much, Ma. We're always very encouraged when we see champions that have lived more than 5 years, 10 years, because it goes to show what many people say about cancer being a death sentence as actually the myth that it is. So whenever we get to meet those people who have lived, there are some of the patients that I know that I've known for over 15 to 16 years, even while I was a resident doctor, that are still my patients today. So we do get to see patients that have lived and have beaten this disease for a very long time, and it always encourages us. That is why we keep doing what we do. So thank you very much, Madam Khadija, for that comment. And I'm still available for all kinds of questions related to the survivorship phase of our disease. Thank you.
Okay, champions, if you have a question,
please have said the survivorship phase. It's not the survivorship phase of our disease, it's the survivorship phase of our journey, because it's actually a journey. Sorry about that. Thank you. So over to us.
Okay.
Good afternoon, doctor.
Good afternoon.
Yeah, good afternoon, ma.
My name is Otene. I'm calling from Lagos.
Okay.
Okay, I have a question.
Great.
Or rather, some questions. Okay, I was diagnosed April last year, and I had a mastectomy in December. But since after then, yes, I've been I've run a series of tests ever since, and now I've been asked to go for, in June, actually, I was asked to go for radiotherapy, but I haven't gone yet. But I noticed every time I keep having this tightening effects on the side of the maxotomy, under the armpit down to the arm, and it's so uncomfortable, very, very uncomfortable. I've had to go back to the hospital. They've run series of tests, scan and all, which says there's nothing there. There's a mass there, like a sac. They said, oh, maybe there's water retained and all, but after all the tests, using needles to prick the place and all, they said there was nothing there. I was safe. But I keep wondering, why do I still have that tightening effect? Why is it still swollen? Is it because the lymph nodes were taken out, or what exactly is the cause of that?
Okay. You said you had a series of questions. So if you would add all, I think it might be easier now that I can hear you clearly. At least I've gotten this one down and I'm ready to answer it. But if there is any other one.
Okay, the next one, I've been asked to go for radiotherapy, and at the point when I was going to go, I met a few people in the hospital, talks here and there, and I think I chickened out. That was part of why I chickened out. Oh, you are going to get burnt. Oh, it's really going to be painful and all sorts of things. Then I haven't done it, but I'm hoping to gather the courage to go and do it. What is the effect of staying away for so long? Because right now I'm not on any medication.
What did you say?
I'm not on any medication. I just try to stay healthy, fruits, vegetable, and just stay healthy generally. And then I talked to someone 2 days ago. She's also a survivor, and she was telling me that she was given the option of having reconstruction immediately the breast was taken out. Why are we not giving that? She's in the UK though, and I was wondering, why are we not giving that kind of option? Nobody even talks to you about the kind of after effects. How do you manage it? How do you survive it? No such talk was said. A lot of things I know is based on talking to people and reading.
Okay.
Yes.
So, so 3 questions. Is there another one?
None for now, no.
All right. Well, first of all, you talked about noticing some tightening and some swelling on the side and probably on the arm. You didn't mention the arm, but I am suspecting the arm might be involved where the surgery was done.
Yeah, the arm just gets that tightening effect, yes.
Yeah. Now, the truth about it is that it's usual, it's common. And it could be caused by more than one, reason. All the more reason why it's either we do a proper workup or we at least assure ourselves that it is less likely to be caused by a residual cancer by doing the proper full treatment. Let me explain. Now, whenever we get an injury and the injury heals, we get what we call a scar. And for every other normal kind of injury that we get, we will realize that the scar, if you look at your skin, in the various places where you have had an injury before and it healed completely, that part of the body is never the same. It's the scar involves some kind of pulling of the skin together, some kind of tightening of the skin together, right? So scarification from the injury of the surgery, because the surgery itself is an injury and it would heal. And when it does, even if there is no residual cancer left behind, the healing process involves what we call scarification, formation of a scar, and that scar involves contraction, pulling of the skin together, tightening. So that alone could be responsible for the tightening that you feel. But that is just one reason. Another reason could be the type of surgery that was done. You had a mastectomy, but the surgeon doesn't just go in and take out the breast. The surgeon takes out the breast, then he chases some other parts of the body that are close to the breast and are very, very likely to be involved by the cancer. One of those parts of the body is what we call the axilla, the armpit, the hole under our arm when we raise our arm. There are lymph nodes. There are lymph nodes in that part of the body that the job of the lymphs, the job of the lymphatic system is to drain water from other parts of the body to the heart. So you can imagine that it's like a pipe, it's a tap. Apart from your vein and your veins, which draw blood from your fingers all the way up your arm back to your heart, there is also the lymphatic system, which is another system of pipes. That is where the lymph nodes are located. So because the doctor is hunting out lymph nodes, because he knows that they are high probability sites for cancer involvement, what he does is that he is not just cutting out the lymph nodes, he is cutting the pipes that are supposed to serve as a drainage upwards for fluid, for water, for lymph up to your heart. I don't know if that makes some sense, but invariably, what the surgeon does in the course of his surgery is to cut and block and damage a lot of the lymph channels that are supposed to drain water. So it's like you have a pipe, you have a series of pipes that have been outlined, and suddenly all of them are blocked or cut or something. Their ability, their efficiency at draining is significantly compromised. That leads to swelling in that part of the body, because when lymph is not finding its way upwards to the heart, it begins to accumulate and begins to cause a swelling. Now, the third reason, which is actually the reason we dread and we do not even want to think about, is that knowledge that there is always the probability that the surgery was not adequate. The surgeon only goes in there and takes out what he can see. But when we are dealing with cancer, we are dealing with something that is microscopic, that can only be seen at the cellular level with a microscope. So there is always that chance that the surgeon would leave some cancer cells behind. That could also be responsible for the residual cancer cells growing, could also be responsible for blocking some of those same channels that were not even blocked as a result of the surgery. And that would eventually lead to swelling in that arm. So you see, there are at least 3 reasons I have given why you could have that tightness and that swelling in that arm. But out of all of those reasons, the third one, which I mentioned, is one reason that we can do something about. That actually, at least to ensure that there is no residual, that is the reason why, even I'm heading actually directly into your next question, because your next question talked about radiotherapy, which you were advised to do, which you have not done. Because the surgeon who did the surgery is aware that there is always the probability that he could have left something behind, that is why even after surgery, he recommends that the patient goes to have radiotherapy, so that the radiotherapy will help him to burn out the cancer cells that could have been left behind inadvertently as a result of the surgery. So refusal to go for the radiotherapy for whatsoever reason is like exposing yourself to incomplete treatment or inadequate treatment, and the consequences are not that good. Let me explain. You see, I always tell my breast cancer patients that breast cancer treatment is like a table or a chair. Why? Because a table or a chair usually stands on 4 legs. Now, there are 4 legs, 4 major legs in the treatment of breast cancer. Surgery is one of those legs. Radiotherapy is a second leg. Chemotherapy is a third leg. And immunotherapy or targeted therapy is a 4th leg. These 4 legs need to be under that table or chair for that table or chair to be stable. The moment, for whatsoever reason, I mean whatsoever reason at all, any one out of the 4 legs is knocked out, that table begins to wobble. Now, there are reasons that might not even be due to us, due to the patient. There are reasons that might even be due to the disease itself. For instance, we take out the breast tissue and we do what we call immunohistochemistry on it to find out if by nature that breast tissue is expressing certain receptors that would make it amenable to hormonal therapy. The moment it is not amenable to hormonal therapy, there's nothing we can do about it. It means we must take hormonal therapy off the table. We must take one out of the legs, out of these 4 legs off the table, ab initio, not because of anything the patient did, not because of anything the health system did, but just because by nature of the tissue of the breast cancer itself, it can only have the remaining 3 modalities and not the 4th. And that is why most of the time we say those patients that do not express receptors that make them amenable for treatment with hormonal therapy usually do not have as good outcomes, as good treatment outcomes as those that get the opportunity to have the 4 legs. So you see, what you are doing right now is depriving yourself of a very, very, very important component of the legs, of the 4 legs, of your cancer treatment. You get the point. Now, radiotherapy is absolutely, absolutely painless. I must just tell you that. If I take a flashlight and I shine it on your skin, you will only see a light on your skin. You will not feel any pain from a flashlight, from a torchlight, if it is flashing on your skin. That is exactly how radiotherapy feels. Absolutely painless. Absolutely. I repeat that over and over again. Standing under the sun is 10 times more painful on your skin than standing under the radiotherapy machine. The way the radiotherapy, the radiation kills cancer cells is not the way most people think. Most times we get patients that are under radiotherapy and it takes them the first 2-3 weeks before they even begin to notice anything at all. Initially, they just come out every day and say, hi, is that all? Is that all? They keep asking, is that all? Until 1, 2, 3 weeks down the road, when they begin to notice the skin over which they are being treated getting a little bit darker or something. But the point is that it is a safe treatment. It is an absolutely necessary treatment. And anyone for whom it has been recommended, who chooses not to take it, is actually taking a risk with the possible outcome, because it is like knocking off one leg out of the 4 legs of this table or chair that we're talking about. Now, the third question you asked had to do with breast reconstruction, and I must agree with you. We don't commonly talk about breast reconstruction in this part of the country, in this part of the world. It is beginning to come up right now, but that is not necessarily an issue with the oncology team. It is more of an issue with the plastic surgeon, because the specialist who does a breast reconstruction, is a different specialist in medicine. Those are plastic surgeons, those are cosmetic surgeons. And until recently, we did not have a lot of plastic surgeons that took up interest in breast reconstruction. But we are beginning to have them. I know at least 3-4 that are my close friends that are beginning to talk about breast reconstruction. And until we begin to get more of them coming up and getting them to see more patients, the more they do the breast reconstruction, the more their skills will improve. And then we will now begin to get as good breast reconstructions in Nigeria as we have in some other advanced parts of the world. So it is actually a concept that it has been there for a very long time in other parts of the world, but it is gradually beginning to come up in this part of the world. But I assure you, it's catching on like wildfire. And very soon, most of our breast cancer patients are likely to get breast reconstruction. However, let me just round up by saying that it also depends significantly on so many factors. No breast surgeon or no plastic surgeon would want to do a breast reconstruction in a patient in whom he is not sure has had a clear chest. That is, the chances of cancer recurrence, the chances of breast cancer recurrence are minimal, because nobody would want to go through all of the pain of a breast reconstruction, and then just after they have had the breast reconstruction, they begin to see breast cancer lesions in that same reconstructed breast. It is going to be like lightning striking in the same place twice. It will be devastating. So even our diagnostic facilities will have to improve. Even our evaluation facilities have to improve significantly, such that we could get to the point where we can look at a patient and say, because of A, B, C, D, E, I can say that the chances of this patient having a recurrence of this cancer are very, very, very slim, if not nil. So this patient will be a good candidate for breast reconstruction. I don't know if I was able to answer your question the way you expected, but
yes.
All right. Thank you very much.
Very satisfied. Thank you.
Yes, ma'am. Thank you.
Okay. Ade, in fact, from your words, that thank you very much. I want to believe there is no follow-up question, right?
No, I'm fine.
I like your style. You don't want to take chances. Ask the whole question at once.
Yes, that's it.
Very smart woman. Okay, Dr. Otene, you have a similar question, but because this our support group, we give everybody voice. I will ask it again, so that if there's anything you want to add, you can add it. So I'm just go ahead and add 3 questions, but you've answered a bit of it. So this is a question from one of our powerful sisters. She said, "Good evening, champions. Please, I want to know how radiotherapy works. I have read online that it takes about 5 days a week, say Monday to Friday. Is radiotherapy painful? Is the side effect serious like that of chemotherapy? As a career-driven person, can I still go to work while taking radiotherapy or stop working? How does it work? Thank you. I'll ask the next question, Dr. Otene.
Okay, great.
The next question is also from another champion. She says, "Good afternoon. Please, what is the essence of radiotherapy in breast cancer or other cancer treatments?" The third question, also from the same champion: "What is the chance of a breast cancer survivor getting pregnant after recovery? Is it possible or not? Is the possibility high or low?" I will stop here, and then I'll be picking other questions, and then I will ask.
Great. All right. Very, very interesting questions. How does radiotherapy work? Okay, maybe I'll just take 1 or 2 minutes to explain something, a concept that I believe most of us will grasp. Now, radiotherapy is use of radiation. And not just use of radiation, but use of what we call ionizing radiation to treat cancer. Now, what is ionizing radiation? Radiation is all over around us. The light that we see, the sunlight that we see, the white light that we see when we switch on a bulb, right? Is radiation. The energy that we use in our microwave is radiation. Infrared is radiation. What we use on our phones to speak, right, is radiation. So radiation is all around us. The difference is that most of the radiation that is around us is not ionizing. It is non-ionizing. What does it mean for radiation to be ionizing? It means that radiation is packed with enough energy to start causing what we call ions in the body, to start causing what we call charged particles to appear within the body. So what radiotherapy does is to begin to make the body to form what we call charged particle. Actually, most of what it does is splitting water in the system. That becomes a little bit complicated. I am conscious of my audience, but that splitting of water into charged particles within the system is one of those major ways that radiation is able to damage cancer cells. But as it is damaging the cancer cells, it also has the potential of actually damage, because it is water, so water flows around the system. So it also has a very, very high potential of damaging even normal cells that now have charged water in the system. And that is why everything we do about radiotherapy is about precision. That is why we will not use radiotherapy to, you will never hear us irradiating an individual from head to toe, because we know that it will expose too many of his tissues to radiation, and that could be dangerous to the person. Everything about radiotherapy is about localization. You are trying to limit the area of exposure as much as possible, because you know that irradiating normal tissues will also lead to damage in those tissues. So you try to restrict your radiation to the cancer as much as you can. Radiotherapy, like I mentioned earlier, is not painful at all. For many people, it takes even weeks before they begin to see that anything is happening to them. And it's usually what we call a conventional fractionation. We break it into beats. We're administering the radiotherapy to patients in beats. So we call each beat a fraction. If a patient goes under the machine once, it's called a fraction. So there's what we call the conventional fractionation. That is the fractions that we give most of the time. It's actually a 5-day treatment. But how a patient gets treated depends on so many factors and what the radiation oncologist prescribes. So there are patients that we give everyday treatment apart from Saturday and Sunday. There are some patients that we give every other day treatment. That is Monday, Wednesday, and Friday. There are patients, we tailor it based on so many other factors, but it is usually given in beats called fractions. And the truth about it is that I will not lie to you. Radiotherapy has side effects, but most of those side effects are side effects that we will only see cumulatively over time. It is like you go under a light, you come out, you didn't feel anything. You go under the same light tomorrow, you come out, you don't feel anything. But by the time you are going under that same light for the next, for the 7th time, for the 10th time, for the 15th time, you on your own begin to see some effects of that light on your system. Apart from general effects where you begin to feel a little bit tired, easily fatigued, some weakness and co, what side effects you would exhibit depends on the site that the radiotherapy is administered. For instance, you will not expect somebody who is having radiotherapy in the neck to have the same symptoms with somebody who is having radiotherapy in the pelvis for cancer of the cervix, for instance. So while the person that is being treated for the cervix, which is a pelvic organ, may be having issues that are looking like diarrhea or some difficulty in passing stool or some difficulty in passing urine because those organs are down there, the person who is being irradiated around the neck area will begin to tell you that he's having some difficulty in swallowing. But like I said, most of those effects tend to start occurring when the patient has gone like halfway, either midway or 3/4 way through their treatment. So we tend to just gradually manage those symptoms until the patient is through with their radiotherapy. So yes, they do have side effects, but those side effects are usually manageable if the radiation oncologist who is administering the radiotherapy knows exactly what he is doing. Because like I said earlier, so much is relying on precision of the treatment. If the radiotherapy is being administered in the same town where you live, you can actually go to work. Lots of, like I told you, the patient will just come in, you don't spend more than a minute under the treatment, under the machine. You just enter the machine. After 30 seconds, they say, madam, you can go. You won't feel nothing, really. So you can actually come from the office, have your radiotherapy, and go back. Maybe towards the end of the treatment, when it begins to accumulate some side effects, and those side effects begin to get a little bit unbearable, it's possible for your doctor to just give you an excuse duty to cover, but it's usually more in the tail end of your treatment. But unfortunately, what I just described now is for a patient who is living in the same town where they're having radiotherapy. But these are very, very few. Why? Because radiotherapy facilities are very few and far in between. They are very few across the country. So most of the time, for instance, I am in Calabar right now, and lots of the patients are seeing are coming from Edo, coming from many states across, because they have to travel long distances to access this important treatment that is not scattered all over the country. And it's a treatment that you will need to receive for like 4, 5, 6 weeks at a stretch. You get it? So you can imagine having to be in Calabar for 6 weeks, Mondays to Fridays, every day receiving treatment. That's not somebody if his work is in Benin, he cannot come to work. But for those of you in Lagos, for instance, if you're receiving your radiotherapy in Lut or in Marcel Ruth Hospital, it's going to be very, very possible for you to be receiving your radiotherapy and going to work. I think all of these answer the first questions. The second question is the one that asked, what is the essence of external beam radiotherapy? The truth about it is that it is absolutely essential. Because like I said, the surgeon is not able to tell you with absolute certainty that his surgery, which took out the breast, was able to take out every cancer cell that is within that vicinity. He is dealing with something that is microscopic, and he will not be able to give you the assurance that his surgery is adequate. So he needs an extra backup to cover the field of his surgery. Invariably, he's saying, just in case my surgery was not adequate, at least let me also have something else that gives this patient a greater assurance that this disease is not going to come back. Patients who have had radiotherapy after surgery tend to have less cancer recurrence within the site of the surgery, because the chances are that radiotherapy would have significantly taken care of the small cancer cells that the surgeon left behind or spilled in the field in the course of his treatment. Breast cancer patients have, I know lots of my breast cancer patients, at least I've been in this job for quite a while. So I have a lot of breast cancer patients who have delivered. After they have had chemo, they have had children. After radiotherapy, they have had children. Now, carefully, I am selecting my words carefully. I say breast cancer patients. A breast cancer patient who is still desirous of having children can easily talk to the doctors, and they find out how they factor in protecting her ovaries in the course of the treatment. It guides how they select what chemotherapy they give. It guides how they select the hormonal therapy they give. It guides whether they will think about ablating the ovaries or not, and all of that. However, there are other cancers in which it becomes far more difficult to protect the woman's ovary. You can imagine if somebody has cancer of the cervix, for instance, or cancer of the anus, or cancer of the vagina or the vulva. That is down there in the pelvis. That is still the same area where the ovaries, both ovaries in the woman, are situated. So invariably, it becomes difficult to irradiate those sites that have a cancer without irradiating the ovaries along with the sites. And the dose of radiation that the ovary can bear is far, far, far lower than the dose of radiation that the cancer of the cervix, for instance, can bear. So before you end up treating the cervix to a dose that is adequate or sufficient for control of cancer, you would most likely have already knocked up this woman's ovaries. However, even in such cases, there are options. I know, for instance, that there are patients that, because they are highly desirous of children, before they undergo pelvic irradiation, they get to have a surgery where the surgeon translocates their ovaries out of the pelvis to another part within the same patient. That way, he is keeping the ovary out of the field of radiation. That is a possibility. I also know that there are, just as they have sperm banks, there are now, ovary banks. We can harvest cells from the ovary. We can harvest ovarian eggs. We can store them such that even if the woman has had her complete treatment and is now very, very okay, she can go through what they call IVF, in vitro fertilization. She gets that egg that has been stored in the sperm in a bank, fertilized outside her body, and then the product of the fertilization, the zygote, the fetus, is transferred into her womb, and she's able to carry the baby. Some even are forced to get a surrogate mother and all of that. So there are options to be considered if delivery is of absolute importance. But it is important to make it clear to the surgeon and to the oncologist from the beginning, before the treatments commence. Because what we see most of the time is a situation where it is after certain things have been done and damage has been done that the patient now says, I didn't know, or I wasn't hearing when you were telling me that this treatment can cause this and that, and a lot of confusions now ensue. I don't know if I was able to answer those questions. Thank you.
Wow.
Hello, good evening, sir.
Good evening. Who is speaking?
I am Mrs. Obala.
Okay, go ahead and ask your question quickly. We're 10 minutes to the closing time.
Please, give me audience. Let me just ask question.
Oh, Mama, sorry. Go ahead.
I was diagnosed October last year.
Okay.
So I did biopsy and then did the first line chemotherapy from December. Then it came out I am triple negative.
Wow.
5/9. So my question, after that I did mastectomy, total mastectomy with auxiliary clearance. 4 lymph nodes were harvested, 2 were positive and 2 were negative. So after that, I now did adjuvant therapy. Then I said I took the last chemo 13th of July. Then by second week of August, I've started the radiotherapy. But before then, I had a fever. On my way from down east here, I had fever. So I examined myself, I noticed there was a lymph node still at my armpits. So when I went to look, I told them that I palpated a lymph node. So the examining doctor said she couldn't palpate any. So when they did CT scan, the CT scan was able to pick the lymph node. Yes. Now I was now placed on capecitabine.
Capecitabine, okay.
Yes. So while I do the radiotherapy, that there is this fear. I don't know whether the radiotherapy will be able to handle that. It's no longer palpable now.
Yeah, that's the point I wanted to. The truth about it is that they are likely to involve that lymph node in the field of the radiotherapy.
Yes,
so the chances are that the radiotherapy will melt that lymph node, and it is likely to disappear. But because there is a lymph node, that is also why they now placed you on the capecitabine. The job of the capecitabine is to make themselves double sure that it will control the disease. You get it? But the good thing is that you are on external beam radiotherapy, so the chances of tumor control are quite good. Are you clear, ma?
Yes.
That is, in fact, what you just explained now takes us back to what I was explaining a bit earlier. So you see, if you had just relaxed and said you will not do radiotherapy, and we are not sure, you see, in this case now, the surgeon left residual cancer in the lymph nodes. And it is those residual cancers that you are palpating right now in the armpit. That is why we don't just give one treatment and stop there. Because you are dealing with things you cannot see, you give one treatment and follow it with another and follow it with another, with the mind that if this one doesn't clear this disease, this one will and that one will. You don't have the luxury. You don't have the luxury of being absolutely sure from the beginning.
Now I want to ask though I'm no longer palpating, I've received the 10th session of the radiotherapy. It's no longer palpable, as in the thing has dissolved. But I want to know, will the radiotherapy actually kill it? You know, with the survivor,
you are asking what you will never get a doctor to tell you. That is the intention. The doctors are doing everything they can, but they will not take out their neck and assure you that what they are doing will definitely, absolutely achieve what you get it. You know, if you see this slogan, doctors will always say, we only treat, God heals. What you are asking is for the doctor to assure you that his treatment will heal you. But he is not God. He doesn't know tomorrow. He can only treat and hope that his treatment heals.
Okay, that time when I noticed it before my radiotherapy, I even asked the doctor, can I go in again for surgery so that physically they can remove the lymph node? He now
it would have been a possibility. It would have been a possibility, but it would have also meant that you must slow down and wait for the surgery wound to heal. And that will not be, that will also now delay your treatment. Are you getting it?
Yes.
Yes.
The next one I want to ask, you were talking about a table on 4 legs. Like we that are triple negative, I had to seek different opinions, and all of them came out triple negative. So I missed something you were saying. It doesn't mean
the point I'm trying to make. That was the point I was trying to make. That it means that those who have triple negative, generally the outcome is not as good as those who do not. Why? Because being triple negative takes out one of the legs of the treatment already because of a factor that is not anybody's fault. You get it? So while the other patient gets the benefit of 4 different treatments, you only get the benefit of 3. And that is one of the reasons why triple negative patients, most of them do not do as much as well as those who are not triple negative. You get it?
And there's no way we can get the 4th one.
You do not have the hormones, so why would they give it to you?
Okay.
You get it?
Okay.
All right.
Thank you so much.
You're welcome. Sorry, ma'am, I'm giving it.
Wow. Wow, thank you so much. And Mommy Jane, thank you so much, ma'am, for your question. Very valuable question as well. Thank you. Yeah. So we have a champion who have raised her hand.
Good afternoon, champions.
Yes, champion, please go ahead and ask your question, please.
I'm Okusanya Oluwatoyin.
Yes, Tony.
I finished all my treatments February. I was diagnosed last year, and I started with chemotherapy. I had bilateral mastectomy. Then after which I went for my radiotherapy. I want to ask a question. After the old treatment, I noticed I started having issues of breathing.
Yes.
Which
sorry, you said after the whole treatment, you noticed, sorry, somebody distracted me. I didn't hear the last statement.
I was having issues of breathing.
Okay, difficulty in breathing.
So
difficulty in breathing.
I went back to see the doctors. I was told to run some tests.
Okay.
Which the tests says my ejection fraction was low. So I was referred to a cardiologist. So since then, I've been on treatment for heart failure. I don't know. I want to ask, how is it related to the treatment? How is it related to me having issue of heart presently now? Because I wasn't having anything like that before the issue of breast cancer comes up. Is it the treatment that caused the heart to be malfunctioning or what or something? I don't know.
Okay, thank you so much, Tony. Doc, do you want to answer the question now, or should I ask you additional questions that have been asked? Hello, Dr. Otene. Okay, I think maybe, I don't know the people that are distracting Dr. Otene. We'll fight those people. Oh, we don't want any waka waka. Oh. Eh? Yeah, but while we're waiting for Dr. Otene, please, I want to encourage everybody, just use the chat box and send your kind words. If you're enjoying this session, you can just say hi, or you can just say thanks, Dr. Otene, if you're enjoying this session. We just lost Dr. Otene, but I hope he will join us in a very short time. So while we're waiting for him, please feel free to drop your questions or probably just to show our appreciation to him. Most of you all know that our doctors are really, really, really busy. So if anyone have brought out their time to really come speak to us to this town hall meeting, I think they deserve all sort of appreciation, because why this is really important is that patients don't have the opportunity to ask all the questions that they want to ask to doctor, and having access to them could be difficult. But we at Project Pink Blue are creating this opportunity to ensure that patients that could really openly and transparently ask questions to Dr. Otene is back. Dr. Otene is back.
I was trying to do a lot of things at the same time. So, but the basic thing I was trying to say is the fact that there is no way you cannot easily tell if the heart failure you are complaining about is because of the cancer or because of the cancer treatment or not. Because any individual could still be entitled to getting heart failure, whether the patient has cancer, either cancer as a disease or treatment of cancer in their history or not. So there has to be that trying to absolutely evaluate to be very, very sure that that is what is responsible. Otherwise, it becomes very easy to accuse the health system of being responsible for what they are not. But I must say that there are breast cancer treatments that predispose an individual to getting cardiac failure. Did I answer your question properly, or is there anything else that I didn't cover?
I'm not really clear with the answer. Because before the treatment, before the
aspects you want to be clear with.
Before the issue of cancer or no cancer, I never had any issue of high BP, high blood pressure or something. My BP is always normal.
That is why I am saying that. Now, are you with me? Okay, finish your question so that we will not be interrupted.
After the surgery part that I started noticing the breathing issue.
That is why I am telling you, there is no surgery, there is no breast surgery that causes hypertension or cardiac failure. Are you getting it? The treatments, the cancer treatments that even predispose a patient to getting cardiac failure are chemotherapy with certain particular agents. And that is the reason why every oncologist, before he places a patient on those agents, he does certain investigations to assure himself that the heart is good before he even places the patient on those agents. Certain things could happen that just seem to happen around the same time, and we quickly begin to think that they are related. But in the actual sense, they might not be, right? Surgery will not give you cardiac failure, but the surgery could be what drew your attention to the fact that you are having cardiac failure because for the first time, you are forced to be lying in one place and you notice the strain on your body. So some of those things could be related, but they might not also be related. And that is why I said there will be the need to properly evaluate to be sure of what is responsible. But I will not be in a position to categorically say. Why? Because we have thousands of patients with cardiac failure. How many of them have had surgery? How many of them are cancer patients? Very few. So invariably, it means any individual could get cardiac failure. So if two things happened, but they are both happening in the same patient and they seem to be happening within the same relative space of time, it is very easy for the patient to say this is happening because of this or that, but that it might not absolutely be unless we are able to properly investigate and situate the new problem within the context of the older problem. I hope I was able to answer it better now.
It is well. It is well.
Tony.
It is well.
Tony say it is well.
Yes, from the content of his answers, what I could pick from his content of his answers is that he said before the treatment, the doctors would have made some investigations before placing that patient on chemotherapy. Which was all what they did before the treatment.
Tony, hold on.
Okay.
Tony, hold on. Can I come a little bit? I am a psychologist, and I also have a psychologist here in the building. And
okay.
I want to say something. You know, that could also be a psychological part of having a, you know, cardiac hypertension, you know, all these other things that comes around when you have a distressing situation.
Thank you.
For instance, someone who have been very healthy, living her life, doing everything possible to have a healthy family, and one day they just announce to you that you have cancer. It could trigger a lot of things in your body.
Thank you.
You understand? Yeah. So, from a psychological point of view, I'm just trying to say that is what we call in psychology. It's called somatoform disorder.
Yeah.
You know, something that, you know, it might not necessarily be, but it could be. You understand? Because the body is undergoing a lot of processes, and then even the hypertension, every other thing can now come to play. So I want to believe that what Otene or Dr. Otene is trying to explain is that if Dr. Otene is seeing you one-on-one now, he can tell you some radio diagnostic test or biomedical test or diagnostic test that you can do now, and he can tell you 100% this is the cause of the cardiac disease.
Exactly.
But he cannot at this time because this is an online psychotherapy, an online oncology care and support. So what we want us to do, we have done this in the past, is we can talk one-on-one. Shola, please raise your hand in the chat box. You can connect with Shola, and if there is need, we can connect you with Otene for maybe more personal support. And if there's even a need to provide you with any other support from our database of doctors that we have across the country, we can help you with that. Tony, I don't know if this is fine.
I'm okay with this now.
Tony, give us a small clap. Now let's know you are happy.
I'm okay. Thank you so much.
Dr. K, you wanted to say something. Let me allow you to say something before we go.
No. I think what you have said has actually summarized what I would have said, and it makes a lot of sense. The whole thing is, you do not attribute a problem to a cause until you are able to establish that that problem actually is that cause is actually the cause. So a lot of things could happen at the same time, but it is investigations, just like you have said, proper history, proper investigation that eventually points us out in the right direction of what really the issue is, and then we're able to sort it out. That's just the point.
Okay, thank you very much. So please, Dr. Otene, we're already running out of time. I know we told you that we'll start from 4 and finish by 5. But sir, there are more questions. There are even 2 people that are raising hands. So sir, please, we want to appeal. We don't know if you want to give us a few more minutes.
No problem.
Thank you so much. Please, please, ma, please.
Hello, good evening. Hello, good evening.
Please, ma, give me some small time. And we have some questions in the chat box that we want to answer, want to ask Dr. Okene, then we can come back to voice questions. Chimeze, I will ask the question and then give you the opportunity then before Dr. Otene. Yeah. So please, let me quickly take...
Rosie, I would have just preferred you give the champions more time to get their questions answered. So that if there's still time towards the end, I'll just make a 3 minutes comment or 1 minute comment.
Thank you so much. Thank you so much, our able psychologist. Thank you so much. Okay, let me quickly take on some few questions, Dr. Otene, from the chat box. And the first question says, what are the policy initiatives that are underway in Nigeria to address the lack of standard cancer treatment facility and radiotherapy facilities? Because we don't want to mention any facility, I have removed the name of the facility that has been mentioned here. And then we move to the next question, please. Another question, this one said, hi everyone, I've gone through radiotherapy and I must say that it is very harmless. You won't feel a thing. Like doctor said, it took weeks before I noticed the color change. Just make sure you don't wash the area, else there will also be injury in the affected area. Good. Then we also have another, this is a comment. He said, thank you for the talk so far, insightful. I think I can mention the name of the person. This is from Dr. Oge Ilebunam, a very strong partner of Project Pinglu. She's joining us from Lakeshore, Lagos, another very important treatment center in Lagos. So she said, breast cancer management is a multidisciplinary team approach with oncologists and surgeons, etc. So it is unlikely a patient would be referred to a plastic surgeon for reconstruction if they would have made a decision based on criteria and guidelines for reconstruction based on many factors. A plastic surgeon will defer to joint discussion with these other specialists. It is unsafe to be managed without specialists speaking to each other closely. Okay, then let me take a few more questions. Thank you very much, Dr. Oge. Thank you so much. Really appreciate, ma'am. This question says, good day, everyone, and thanks for the opportunity. Please, Dr. Otene, what is the importance of BRCA testing during stroke before breast cancer treatment? Dr. Otene, please, sir, let me take more questions so it will be easy. Then this other question is also from a very important champion. She said, thank you, doctor, for enlightening us. Another question, sir. A cancer survivor told me about an injection that is normally given before chemotherapy to preserve the eggs. I wasn't given any. Oh, we lost Dr. Otene. Oh. Hey, we lost Dr. Otene. Okay, maybe we can give a few minutes to have Dr. Otene back. Yes. But champions, thank you all so much for joining. The question has all been coming. It's been really, really interesting. I must really say, I must commend everyone who have really been able to join.
I'm so sorry, Ronsi. A call came. You know, when you are doing this thing with your phone and a call comes in, it disrupts your network and makes it difficult. I had to quickly, the person kept calling persistently. I had to quickly tell him, please, I'll call you back. I'm giving a lecture somewhere. And that's how he disconnected. So I didn't hear the question you asked immediately after Dr. Oge's comment. Thank you, by the way, for that comment, Dr. Oge. I know that you were asking a question. No, you asked about BRCA. The last question I took down had to do with the importance of BRCA testing. And then I didn't hear the next thing after that.
Okay. So do you want me to go ahead and ask the other questions?
Okay. Well, I just got into a place where I have a paper and pen. So it might be easier and faster if I do take down the questions so that I can just run through the answers step by step, right? But I know that for now, it's two questions really that are hanging. Okay. Why? Because what I have so far is 2 questions and 2 comments.
Okay, let me.
The person who gave a comment regarding how safe radiotherapy actually is, and talked about washing the place with water. Yes, I agree with you, and so that's a comment. I just wanted to thank the person for that comment, and Dr. Oge's comment was also a comment, more or less, which I agree with. Ideally, the way the multidisciplinary team setting is, it is supposed to be such that at the beginning, everybody that is involved in the management of these patients sit down and take a decision. Each person knows and agrees on where and when they should come in. And once the treatment plan is drafted for the patient, each person already knows exactly where the patient is going to and for what. That is the standard. That is how it should be. But of course, we all know that the Nigerian system is not as straightforward as that in most places. It's easy, for instance, to get all of the specialists in Lagos. It's possible, for instance, to get all of the specialists in Abuja. But because it's not like there are only 2, 3, 4 radiotherapy or cancer centers designated in the country where once anybody suspects a cancer, they push the patients there, you end up getting a lot of patients that are being managed in centers where that multidisciplinary, the various components of the multidisciplinary team are not complete. Am I saying it's the right thing? No, but that is what we have. And because that is what we have, we also have to factor in what we do for those patients that did not get that full component of a multidisciplinary team review at the inception of their treatment. But for those who are able to get, it's perfect. That's the ideal way. So the 2 questions I got were the ones that talked about what are the policies that the government is making to ensure, better access and quality of treatment across the country, and the other one that talked about BRCA testing. What is the significance of BRCA testing? I don't know if so you were asking a 3rd question before I switched off. I just clarified that those are the 2 questions that I seem to be hanging on right now.
Okay, let me ask the 3rd question then, so then you can pick and answer them. So the 3rd question says, thank you, Doc, for enlightening us. Another is a survivor told me about an injection that is normally given before chemotherapy to preserve the eggs. I wasn't given any. I asked my oncologist about it and he said he forgot. Since I wasn't given any of this injection to preserve my egg, what is the possibility of me getting pregnant in the future? I am only 26 years old.
Okay.
Yes, over to you, doctor.
All right, thanks very much. Well, with regards to government policies, I am actually a government worker and not necessarily a policymaker, right? But I do know that it's before now, even the policy direction of government with regards to cancer care in this country was not clear-cut. But over the last 7 to 8 years, there has been some significant differences. That was where all the idea of at least having a national cancer control plan started, 2008 to 2003. Now, the essence of that is at least the government is gradually becoming a little bit more deliberate about this thing, realizing that it's a big elephant in the room that they had not been talking about. Once government begins to put policies on paper, they might still be a far cry from achieving the targets of those policies, but at least it starts to give the government something with which to assess itself periodically on and say, oh, okay, we have scored 0% here. Oh, we have scored 40% there. Oh, we have scored 80% there. So the fact that we now even have a national cancer control plan, which was just 5 years just rolled by, and it's in the process of being reviewed for the next 5 years, shows that government is beginning to put policy on paper. Now, there are a few other things. All the Cancer Health Fund that is supposed to make funding available for indigent cancer patients, all the CAP, that's chemotherapy access program that is supposed to make cytotoxic drugs easier for cancer patients to buy, because it cuts down the cost of these drugs to less than 50, and in some cases even 25% of what would have been. Those are initiatives between pharmaceuticals and the Federal Ministry of Health. All the struggles to ensure that cancer care is also included in the National Health Insurance Scheme and all of that. Right now is National Health Insurance Act, whatever. All of those are various processes that from the government end give us the idea that at least government is not turning an absolutely deaf ear to the plight of cancer in Nigeria. However, we know that it is a continuous process, and that is why there are advocates in the cancer space. That is why societies like Nigerian Cancer Society exist. That is why there are so many people always trying as much as they can to put the government on its toes in these regards, right? But for me to sit down and give you a clear-cut, mapped out program on what the government is doing, it will be a little bit difficult, because I'm only an employee of the Ministry of Health and not one of the key policymakers that sit down in the ministry to draft policy. I don't know if I was able to answer that question, but I'll move quickly to the BRCA testing. Now, BRCA is breast cancer antigen, and it is one. Hello, somebody mentioned something?
No, go ahead. I think someone turned
on
their audio.
Now, good. It was noticed that certain individuals have what we call a mutation. A mutation is a change. In this case, a gene mutation. The genes are what make up the individual. The genes are what we inherit from our parents that determine everything about us. How tall we get, how dark the colors of our skin, the colors of our eyes. Virtually everything about an individual is determined by his genes. Now, there are certain genes that can get mutated, that can change. That is, they are not like that of every other person. Now, when those genes change, that change particularly predisposes the individual to certain cancers. So this group of genes called the BRCA gene, there's a BRCA1 gene, there's a BRCA2 gene. They can be normal in an individual, that means there is no mutation. But when an individual is born with mutated BRCA gene, that individual is highly predisposed to getting not just breast cancer, but so many other types of cancers like ovarian cancer and co. BRCA gene is popular, but it's not even the only gene mutation that predisposes to cancers. There are so many other types of gene mutations that predispose individuals to so many other types of cancers. But the good thing is that we are able to test for BRCA gene mutation. So because we're able to test for BRCA gene mutation, we are able to tell an individual who has a mutation in his BRCA1 or BRCA2 gene, and we are able to say, because this individual has this mutation, he is very, very likely to develop breast cancer or ovarian cancer at a much younger age than the average population would have developed that cancer. So do we intervene and do anything in the prophylaxis to ensure that that individual doesn't develop the cancer? If, for instance, it's common for somebody to be above 50 in the general population before they get breast cancer, I'm just giving an example. Somebody who has a BRCA gene mutation is likely to get it even in their early 20s. So when you notice a very high amount of relatives within a family getting breast cancer, or when you notice breast cancer occurring in an individual in whom the age is quite low compared to what the average is supposed to be, you begin to suspect that there could be something that is predisposing either this individual or this family to getting breast cancer early. So could they have a gene mutation? Those are the individuals that you order for a BRCA test for. And if it is found, you begin to do something. Maybe I'll just make two comments, then I can switch to something else. I have seen clearly a family where, okay, while I was a medical student, there was a girl that was just 13 years old. She had breast cancer. She was the last out of her mother's 4 children. All her 3 elder sisters had died of breast cancer. The mother was dead, she died of breast cancer. The mother's sister was dead, she died of breast cancer. The grandmother died of breast cancer. In essence, I'm talking of one disease, breast cancer, wiping off the grandmother, wiping off the mother and the aunt, wiping off the 4 daughters. And this patient I was talking about, this index patient, was the 4th daughter that the late mother had. And she was just 13 years old. Now, common sense will make everybody realize that lightning ideally should not strike in the same place 2-3 times. The fact that it is striking repeatedly in this family shows that there is something. That time that I was doing residency, testing for BRCA gene, I know was not relatively common. I don't think there was anywhere in this country where you could do it. But with the benefit of hindsight, I know that if that girl was tested for BRCA gene, the chances that it would be high, there would be a gene mutation detected would be very, very high. Now, most of us know of Angelina Jolie. She's a popular American film actress. What did she do? She realized that members of her family, are getting breast cancer early. So she went to do her BRCA gene testing and realized that she had BRCA gene mutation. What did she do? She simply went to the hospital and said, take out my breast and take out my ovaries. Why? Because I know that this gene mutation that I have predisposes me to getting breast cancer or ovarian cancer. And I do not want to have breast cancer or ovarian cancer. So take them out. So the beautiful breasts that she has now are reconstructed, and she has no ovaries. She has no problem with that. You get the point. So what it does is it helps us detect individuals who have a high predisposition of getting a cancer, and then they can take a decision on either prophylactically removing that organ that would have developed the cancer. They don't want to wait for the cancer to develop before they treat it. They take action even before it happens. I don't know if I've spent so much time talking about the BRCA part, but I would move to the 3rd question. Now, I do not know, and I must be very frank with you. There are new innovations that are coming up. There's the concept of oncofertility. And there are lots of innovations that even for those of us that are in the field of practice, we are finding it difficult to keep up with. So if there's a new drug that has just been discovered right now that can help protect the ovaries from chemotherapy, I would have to even do some work on it to find out. I'm frank with you. But that again is why, just like Dr. Oge said earlier,
hello,
cancer treatment is not a one-man show. That is the reason why cancer treatment must contain the various disciplines together. Because, for instance, when you're talking about preservation of the ovaries for even while the patient is undergoing chemotherapy or radiotherapy or whatsoever, there's no way I would not talk to my gynecologist, for instance, who is a fertility specialist, who is going to sit by my side and walk the patient through those aspects of the patient's treatment. You get it? So it's not a one-man knows it all thing. But I do know that if a patient is properly counseled from the beginning, if all of these discussions took place right from the beginning, the chances are that we are less likely to run into murky waters. I don't know if I answered these questions, at least in a way.
Wow. Thank you so much. Thank you so much.
Thank you so much, sir.
Yes. Please, I will hand over the mic over to Okenzua Neka. But before then, please, I want to ask all champions, please put your microphone on mic and put your microphone on mute, please. You can only speak when you are allowed so that it will help the conversation, or you can speak when he finished speaking instead of interrupting when he's already speaking. Please, I'm just appealing to every one of us. I know we have some burning questions, so I totally understand. So Taiwo, please, can you put your microphone on mute? I will call on you, please, briefly. Please. Okay, so can we have Oken's Olushola? Do you want to ask a question after Olushola? Then we can have Neka, Okenzu and Neka ask their question. Then before we can get back to a few questions, and then we'll be getting ready to close.
Hello, good evening, sir. You said I should raise up my hand so that Toyin can see me. I don't have a question, sir.
Oh, okay, okay. Okenzu and Neka, please.
Yes, sir.
Hello, good evening, sir.
Good evening.
Thank you very much, Doctor, for this insight lecture. I'm really enjoying it. Welcome. I want to ask you a question about food, spice, turmeric. I was told that hormone responsive cancer does not take turmeric. Like somebody on letrozole should not take turmeric. And I learned turmeric is very good for cancer treatment. So which one do I take? And again, soybeans too, that is protein. They say we should not take it because we are estrogen progesterone positive.
Well, thank God you are the one that is teaching me right now, because those are issues that some of us, that is why, like we always mention, cancer treatment is multidisciplinary, and part of the multidisciplinary team is a dietitian. That's somebody that read dietetics and all of that. Because some of the information that you are mentioning now are information that I am only hearing for the first time, and I've been in cancer management for over 15 years. The point I'm trying to make is that I am very likely to believe that some of those information are not true, but I am less likely to quickly say they are not true, because it means they would only send me to go and confirm if they are true or not. I do know that there are certain things that we ask people not to eat because of certain drugs that they are on. But I have never had cause to tell any of my patients on letrozole not to take turmeric or not to take soya beans and all of that. If there are new things that are coming up, I wouldn't be able to know until I confirm. So I am not being hasty to say those information that you have are myths. I am only saying you need to confirm or cross-check, because again, you said repeatedly, they said, and I didn't hear you particularly say it was your medical doctor, your oncologist, who placed you on those drugs that said all those things that you are mentioning. The essence is that you have one doctor who places you on a medication, and it happens for most of our patients. We have one doctor who places them on a medication, but they have 20 other people who place them on so many other snippets of information that are relevant to that information. And they never get back to their doctor to say, is this true or not? So it causes a lot of confusion in the system. You get the point. So, and that is why I'm also being cautious not to be the one to say, oh, what they are telling you is a lie. But if it were your doctor who had told you, I would have been happier, because I would have said, oh, okay, I have a colleague who has read this thing that I haven't read, so let me also go and confirm it. But I can almost with certainty tell you that I think it is not your doctor, not the oncologist who placed you on letrozole that started talking to you about turmeric and soya beans. It's most likely somebody else who probably didn't know the beginning and doesn't have much of an idea of where the end is likely to be, but just chips in an information right there in the middle that throws a lot of spanners in the works. I don't know if I was able to answer your question.
Okay.
Hello. Okay, great.
Okay. Okay, ma'am, feel free to unmute yourself if you need more clarity. But while we're waiting for that, Taiwo, you can go ahead and ask your question now. After Taiwo, then we'll pray.
Okay, good evening, everybody. Thanks for sparing your time. God will reward you manifold.
Amen.
I'm equally a patient. I've gone through the chemotherapy, the chemo, the operation, and the radio. So I know after the radio, being advised to take more chemo. But this new set of chemo is the after effect is very new to what I had before. But what is more of concern to me right now is that I'm taking time to recover from the chemo. I took one last about 6 weeks ago. The rate of recovery from past experience is faster than this. Aside from that, I'm having tingling on my fingers down to my palms, and it's like 7 to 8 weeks now. I've been had to take a Neurovite, and I just started with Gabaline as well, but it's not coming. I'm not getting results as early as I expected. So I don't really know where the problem is. So,
I'm trying to understand what the question is, but let me just know that
on my palms, tingling and numbness on my palms and the toes.
Even without telling me right now, I have an idea that the second chemo that you have been placed on is either docetaxel or paclitaxel. Do you know the name?
Yes, is that second one you?
Now, from the way I call the two names, you realize that they are both drugs in the same family. They are all what we call taxanes. Docetaxel, paclitaxel, they are both in the same family. It's just that they are not exactly the same drug. But
I don't know.
We give them to patients that we are afraid the initial chemotherapy that they had might not suffice. And we want to be very sure that we are able to keep the cancer down as much as we can. But the common side effect of the taxanes is what you just described. That's why the moment you mentioned the side effect, I told you the drug. That shows you that even your doctor knew it was likely to happen. Sometimes what most patients do not understand is the fact that most of what the doctor does is a balancing act between the benefits a drug will give to a patient and the damage that are likely, the damages that are likely to occur if that drug is not given to the patient. I don't know how to explain it a little bit more clearly, but it's always a balancing act. You are weighing what this patient is likely to benefit if I give this drug, and what are the possible damages that are likely to happen if this drug is not given. Now, if the benefits outweigh the risk, we go ahead and give the patient the drug, even when we know that there are risks attached to taking that drug. So I can always go ahead and give a patient paclitaxel or docetaxel because I know that it is much more beneficial to the patient compared to the risk of having the tingling sensation. So your doctor actually took what they call a calculated risk and realized that you are better off with the taxane, even when he knew the taxane was likely to give you side effects. So yes, we are now done with the side effects. And like you said, we prescribe all of those Neurovite and all of that. The truth about it is that even if they do work, they take a very long time to work. You are talking about 6 weeks that you have been on Neurovite. I'm telling you that you will probably need to be on Neurovite for months, maybe 6 months or even a year. You will need to be on it for a long time. Why? Because now the tingling sensations you are having is as a result of damage to the small, tiny nerves that are at the ends of your hand, that's on your fingertips and on your toe and all of that. They are getting some effect from the chemo and they are responding that way. But nerves do not heal as easily as other tissues in the body. If anything, nerves are one of the slowest healing tissues the body has. So we will need to be very, very, very patient while we allow the Neurovite and the, all of those drugs that we use for peripheral neuropathy, while we allow them, biopentin, Neurovite, they will take time before they are able to exert the effect that we want. Sometimes when the doctor placed you on the Neurovite or the biopentin, it might not even be necessarily to reverse the peripheral neuropathy, because that's what you are having. It's called peripheral neuropathy. It might not be to reverse the peripheral neuropathy. Instead, it is simply to stop it from getting worse. You get it? So continue taking the biopentin or Neurovite, continue taking all of those drugs. If you will get an effect from it, is likely to be long term, not a short term quick fix like somebody just says, I have a headache and you take paracetamol and it disappears. I don't know if I answered your question.
Wow. Thank you very much. Thank you so much, sir.
You're welcome,
taken
sir.
so much of your time and we totally appreciate it.
No problem.
So, champions, we'll be closing down briefly. And I just wanted to take this opportunity to inform every one of you that we have this support group every month, especially for the people in Lagos. Our colleagues who are in Abuja, we also have a support group that also happen in Abuja. In fact, the support group for Abuja is happening in person on the 26th of August. So please get in touch with Project Pink Blue and they'll provide you with all the information that you need. Madam Khadija is on this call and she can provide information about Abuja. And Olushola, who is our coordinator for the Lagos support group, she's also on this call and she will also provide you with information. However, we only add cancer survivors in Lagos in the Lagos support group, WhatsApp group, and Abuja people in Abuja. So if you are in Lagos and you're a champion, you're just joining this call for the first time, please just drop a message in the chat box and Shola will take your contact and connect with you and add you to the support group. Please, you have to only be in Lagos. But if you are outside Lagos, please reach out to Madam Khadijat in the chat box and then she can add you to the Abuja and the other network we have. We'll just allow our major champion, one very important champion, Hadiza Aliyu Manga. She's joining us all the way from Northeast, I think in Adamawa Yola. I'll just give her the opportunity to ask her final question or just a comment, and then we'll have Otene answer that. Then Shola can do a closing remark, then we can close today. But let me ask a question in the chat box that was not answered. He said, Dr. Otene, is it true that one of the side effects of Herceptin is heart failure? If it is true, how can one prevent this deadly effect? I'll turn over this microphone to Hadiza to ask her question or to do her comment. Then we can just turn to Dr. Otene for his final response. Thank you. Hadiza, over to you. Hadiza?
Hello, can you please hear me?
We can hear you, Hadiza.
Yeah, we can.
Okay, good evening all. Thank you, Project Pink Blue, and thank you, Doc.
You're welcome.
I said, please, about the food issue, I want you to clear. I think most of the champions here would like to know. I don't really know about this sugar and cancer. Is there any scientific proof that say cancer patient cannot be able to take sugar? Because this thing has not only been bothering me, I know it has been bothering a lot of people. Is there any scientific proof? Because for me, none of a doctor or my patients, I know that a doctor has ever told him not to take sugar. All this is them say, and go.
Maybe I'll start. Thank you. I think I will start from where you rounded it up, because you actually asked the question and you answered it in a way. Like I said earlier, there's a lot of them say them.
And
say.
sorry,
There's
secondly,
a lot of Google. All right.
Secondly, so that I will round up and finish since they are closing. Secondly, please, Project Pink Blue, for those kind of support group, kindly add patient relative on this, because not only the patients that need this counseling and to know a lot about it, the patient relative need to know more things on cancer. Thank you. This is my question.
Okay. Well, you have answered the question of sugar, so I'm taking
No,
the
I did not
questions
answer.
from
I
behind.
just said, and I asked
I'm
if
telling
there is
you
any
that
scientific
you have
proof.
answered. Why? Because most of what people read about these things is from Google. I belong to so many groups where I read so many things that make me laugh. Now, let me just answer it directly. No, it is not true. And those who say, oh, do not take sugar because it feeds your cancer, as far as I'm concerned, you would have asked them to give you an alternative of what else you could take if you do not take sugar. Let me explain. The human brain doesn't take anything apart from glucose. Your brain. The moment your blood glucose starts going down, the body starts diverting most of the glucose that it can mop up from anywhere and directing it to the brain, because the moment your brain stops getting glucose, it begins to shut down. Glucose is sugar. So it is not even possible to shut sugar completely out of a human system. That human being is dead. In fact, the way our body is wired, if your body is not providing enough sugar from outside, that is enough glucose from outside, the body begins to find other ways of manufacturing sugar from within. For instance, the body actually stores a lot of sugar in the liver. So once your sugar intake starts going down, the body starts mobilizing the stores quickly, starts breaking down what it stored as from the glycogen that is stored in your liver. It starts converting them into glucose for use. If that starts going down to the point that that store is getting depleted, the body begins to undergo what we call gluconeogenesis. It is manufacturing sugar from other components of your body that are non-sugar. So it starts trying to break down sugar from your protein, starts trying to break down sugar from your fat. It starts trying to convert other non-sugars into sugar because it needs sugar to survive. It needs sugar to stay alive. So invariably, but the worst aspect of it is that when you force the body to start converting sugar from an unconventional means, a lot of other toxic byproducts of those processes begin to be produced, and they begin to pile up on the system. So invariably, you are not taking the sugar that the body needs from outside, and the body needs the sugar. So what does it do? It starts producing sugar by converting other components of your diet into sugar within your system, generating a lot of byproducts that become very, very toxic to your body environment. So I don't know if you get the whole point. So it doesn't even make sense that we would want to begin to believe that it is the sugar that is our problem. I think that maybe that just summarizes it, because for me, it's one of the things that I always hear, and it always gets me a little bit off. And I say, how do you survive without sugar? And that's one of the problems we have as cancer patient managers, where we have a lot of patients that come with a long list of the things that they should not eat, but they do not have a corresponding list from those same sources of what they should eat. And as such, you have patients that begin to go into malnutrition, that begin to keep getting anemic, that make it very difficult for us to manage the cancer that they have because they are not eating enough. And they will not tell you, they will not discuss that with the doctor. They will keep it to themselves. And well, I think I've dwelt so quite long on that, so long that I think the question that the other question that was asked is fleeting on my mind right now, and I'm not able to place my finger on it.
I can ask again.
Yes, sir. Yes, sir.
So
Please
the question
do,
is,
sir.
Is it true that one of the side effects of Herceptin is heart failure?
Oh, thank you. Yes, it is true. One of the side effects of Herceptin is heart failure. I agree. And that is one of the reasons why we are careful when we are using Herceptin along with any other thing that could cause heart failure. For instance, adramycin and all of those. But like I said, it is all a balancing act. What the doctor does is a balancing act. So there is no drug that doesn't have a side effect. Even the most common of drugs have their side effects. At every point in time, the doctor is struggling to balance the benefits that the patient is likely to get from the drug with the side effects that the patient is likely to get from the same drug. So a doctor who is giving a patient Herceptin, he might not be able to predict which patient is likely to get heart failure, but he is able to do a lot of heart evaluations. All the ECG he's going to be asking a patient to do, all the echo he's likely to be asking the patient to do are first of all, to even evaluate the status of the heart before he places the patient on a drug that is likely to stress the heart in the first place. 2, he does those tests periodically even while the patient is on the drug so that he would know when that stress which he anticipates could happen on the heart begins to happen, in which case he knows when to begin to withdraw what that stressor is before it culminates in a damage that is irreversible. But it does happen. Not every patient that is on Herceptin will get heart failure. So if we stop patients from receiving Herceptin because we are afraid of heart failure, we will be depriving all those other many patients who would never have gotten heart failure from benefiting from Herceptin. So the only thing we can do is to be as cautious as possible while we are administering Herceptin. The good thing is that because we know it's a possible side effect, we can watch out for it, detect it if it wants to occur before it culminates into an irreversible one, and then do something about it.
Wow. This has been so enriching. Thank you so much.
Thank you so much, Ronsi.
Shola, you're going to do your closing remark, but let me give Chimezie the opportunity to quickly just make his quick remark, then before we can come to you, Shola. Chimezie, our clinical oncologist, please. Clinical psychologist, please. Hello, Mr. Chimezie. Oh, okay. So I think maybe Chimezie is having trouble. So Shola, please, if you can go ahead and give your closing remark and thank you message, then we can close for today.
Okay. Hello. Good evening, everybody.
Yeah,
it has been so much very interesting session. Thank you so much, Dr. Samuel Otene. Thank you for making out time despite your super busy schedule. We appreciate you. God bless you, sir. God bless you.
Amen. My pleasure. Thank you.
Thank you. And thank you to other doctors for the meeting. And thank you to Dr. Ronsi.
You're welcome.
Thank you to Mr. Ronsi for this. Thank you so much. God bless you. And to all the champions that made out time to attend, thank you. Thank you. I'm very sure we all got something in our brain that we'll ponder about. Thank you.
Thank you, everybody.
Thank you so much.
Yeah,
thank you very, very much.
So
all right.
Thank you.
Have a wonderful day ahead, everyone.
Everyone, thank you so much for joining. Please don't forget for next week.